The next pathogen we'll talk about briefly then is Pseudomonas aeruginosa. Like the Enterobacteriaceae, they're gram-negative rods, but unlike them, they are oxidase positive. So oxidase is a reaction that detects a particular cytochrome in the organism, and Pseudomonas has this, and it turns that oxidase reagent, if you look at the lower right-hand side of the slide, purple when you drop it on top of the organism. One of Pseudomonas' nice things, at least from a bacteriologist's perspective, is it is a beautiful organism on a plate. It's sort of a greenish blue color. Sometimes it's red and has a very nice fragrance. It smells like grape gum or grape juice. It's a real distinctive organism. The bad side is it's very ubiquitous in nature. It's all over the environment. It's in the plants that someone brings your patient. It's in iced tea. It's in the salad. It's everywhere. And so it's a very virulent organism which, when given the right opportunity, can cause some really serious infections. So this is a list of risk factors then that open the host up to a serious Pseudomonas infection. Any of us can get this. And I have boxed the ones that are linked to urinary tract disease. So catheterization and kidney stones, which will can both lead to increased risk for Pseudomonas aeruginosa infection. So in terms of virulence factors, Pseudomonas is extremely virulent because it makes many tissue-damaging cytotoxin. It also makes a capsule, which you'll remember makes it very hard to kill with antibody and phagocytosis, so it impedes antibody-mediated uptake by neutrophils and fixation of complement. In the cartoon there are extracellular proteases, hemolysis, toxins. It really damages tissue, and it can move tissue through tissue quite well. Again, it's very ubiquitous in nature. It's in your, people get it in their eyes because their mascara gets contaminated with Pseudomonas if they let it expire. It's resistant to detergents, and so many hospital soaps and things used to scrub the floors won't always kill Pseudomonas. It's highly resistant to antibiotics, and like some of the others that we've talked about, it's very good at forming biofilm. So on your left you see a Pseudomonas biofilm in green, and here's one that was imaged from the luminal surface of a catheter. Okay, can you imagine having that on a catheter inside of someone? Okay, gram-positive then. So Staph aureus, Staph epidermidis, we talked a little bit before. Staph aureus then is carried by many of us in our nose, but it's also on our skin. Staph epidermidis is very common skin flora. They're catalase positive, gram-positive, cocci, and again Staph aureus is coagulase positive. Enterococcus you haven't had. It used to be a member of the streptococci because unlike staphylococci, it forms long chains. They're gram-positive cocci, but they form long chains as opposed to clusters. Because they were streptococci, they're catalase negative. They don't produce hemolysis. And then two lab tests that you may see in clinical vignettes in terms of the lab results, they hydrolyze bioesculin and they're very tolerant to salt. They'll grow in salt. So in terms of virulence factors and more specifics of these pathogens, Staph aureus, I showed you this before when I talked in the skin module. It can be very invasive, and if it becomes bacteremic from a skin lesion or some other site, then it can get to the kidneys to cause pyelonephritis, shown in red. And again, it is very good at forming biofilms, and so it's a common cause of catheter-associated UTI. It's a really virulent organism. Again, for review, Staph aureus is particularly well evolved to defend against phagocytes. You remember protein A binds the FC side of antibodies, which immobilizes them in the wrong direction for function, and it is very good at fighting neutrophils by having catalase to break down the H2O2 produced by the phagocytic respiratory burst, and having leukocidin, which actually lyses the white blood cells. Staph aureus can cause shock by way of the cell wall components such as fibronectin and teichoic acid. Also, as review, the coagulase is not only used in the lab to identify Staph aureus, but it initiates the conversion of fibrinogen to fibrin, and that can help wall off the infection. It's an encapsulated organism, and like Pseudomonas aeruginosa, it makes lots and lots of toxins. So Staph aureus is a particularly virulent bacterium. Staph epidermidis is not so virulent, but it's on all of our skin, and it's rampant in the hospitals, and it's very good at forming biofilms. And so here you can see that they, all the different foreign devices that can be easily colonized by Staph epidermidis. It's also a reservoir for antibiotic resistance, and so that's a problem also. With Enterococcus then, those were the gram-positive cocci and chains. If they cause a UTI, pyelonephritis, they can easily become bloodborne. And one of the things you should remember about Enterococcus is antibiotic resistance is a major problem. So unlike most of the streptococci, they're resistant to penicillins, and a high percentage are now resistant to vancomycin. And that vancomycin resistance has probably been what has spread to Staph aureus from the Enterococcus. All of these resistances were acquired by mobile elements, And the remaining therapies then are dwindling for Enterococcus faecalis. Both of these are found in the gut, by the way, which is why they get into the urinary tract. Faecalis is still susceptible to a couple of these oral antibiotics, but Faecium is only pretty much sensitive to linezolid, so there's not a lot of options for oral antibiotics to these organisms. So I have this in here. This was a recent paper that I thought was kind of interesting, and I thought it would help review some of your antibiotic mechanisms of action lecture. So trimethoprim is an oral antibiotic that is concentrated really highly in the urine. And so because it's such a problem with enterococci to find antibiotics, people wanted to reevaluate trimethoprim. And if you remember, this is one of the antibiotics that works on a metabolic pathway, and that is the production of purines and pyrimidines. And what it does, trimethoprim inhibits the dihydrofolate reductase. And so in vitro, if you look on the table, the MIC of Enterococcus faecalis to trimethoprim just in vitro is pretty reasonable. But if you add tetrahydrofolate to the media, it increases because it bypasses the need for dihydrofolate reductase. But surprisingly and alarmingly, and pretty much stopped any hope of using trimethoprim, is if you test enterococci grown in urine, the MIC is way too high to be usable because it can use the tetrahydrofolate and dihydrofolate present in urine to increase its MIC. And so I put this in there so you can understand better what goes on when one tries to develop antibiotics for testing. You have to look in vitro and you have to look in vivo to see if your MICs are the same. Okay, the last thing we'll talk about is lab diagnosis of UTI. First, specimen collection. So this is a really important step. Because the rectal flora is really close and skin flora can get into urine, someone who just comes into your clinic, usually a woman who has a UTI, then what you advise them is to collect a clean catch midstream urine. And then the way that works is they urinate a little bit, they clean themselves first, urinate a little bit, catch the urine midstream, remove the container, and finish urinating. And that helps the urine only have what's actually in the bladder as opposed to contaminating skin flora. For catheterized samples, then it's recommended that a flow sample be collected. Don't take it out of the bag because urine is, again, a good medium and bacteria really can grow in that bag, and that doesn't represent what's in the bladder as well. And probably the best but most invasive technique for collecting urine without contamination then is a suprapubic aspiration, which should be completely clean unless you don't clean the skin flora well enough. Urine samples should always be refrigerated because, again, bacteria can grow in urine very easily. So once it goes to the lab, they do a dipstick, and for infection, what they look at is the nitrite reaction and the esterase reaction. There's usually some other enzymes that indicate the presence of neutrophils, because again, bacterial infections usually go along with a neutrophil response. They then centrifuge the urine at a low-speed spin, dump the supernatant, and then examine the sediment under a microscope. And again, they're looking for leukocytes, evidence of host response in bacteria. You've had casts probably in pathology. Many casts can appear in the urine sediment, but if they contain granulocytes or white blood cells, that's also suggestive of a kidney infection. Okay, and then a urine culture is one of the only cultures in the lab that's actually a quantitative culture. And so what the lab does is they put a defined volume of urine on a plate, they spread it all over the plate, and then they count the number of bacteria or the number of colonies that grow the next day. And so your lab report is going to give you the number of bacteria per mil of urine. In an uncomplicated UTI, a person is considered to have an infection if greater than 10 to the 5th bacteria of a single species is recovered. With complicated UTI, more than one species can be present and the number of bacteria recovered can be lower in terms of evidence that they have UTI. For catheter-associated UTI, it's very hard to make a good diagnosis. Many species are usually common. The presence of biofilms can confuse identification, and I think this is a really hard thing to diagnose. Suprapubic tap, because it should be so sterile, the isolation of any organism is usually considered positive. Treatment then, antibiotics for gram-negatives are listed above. Again, resistance is very common, so sensitivities are routinely performed in the laboratory on isolates that come out of the urine. Pyridium can be given to women to relieve the pain that it goes with cystitis and drink lots of fluids. And what I'm going to end with is this study that was done. You will hear people say that cranberry juice decreases your risk of UTI because it has a sugar that mimics the receptor of some of the adhesins that UPEC make, but in a controlled study, there is no evidence that cranberry juice is preventive at all. So people tell you that, I think that's probably not true. And as usual, I've ended with some questions that might help you go over the material. Thank you.